For decades, a significant portion of neuropsychological rehabilitation relied heavily on a highly controlled laboratory-style approach. Patients practiced isolated cognitive drills, sorting shapes, memorizing word lists, or performing continuous performance tasks in a perfectly sterile environment. The underlying assumption in clinical settings was straightforward. If a patient could increase their digit span or process information faster on a standardized assessment, those metrics would organically translate to improved functional independence at home. But looking at this split dual-axis chart reveals a persistent clinical failure, widely known as the transfer paradox. On the left, we see clinical test scores rising sharply after drill-based interventions, but on the right, the trend line for actual activities of daily living, or ADL independence, remains entirely flat, leaving a massive gap between test performance and real-world recovery. The structural reason for this paradox is context. A controlled cognitive drill testing working memory strips away the noise, distraction, and multifaceted decision-making. In the real world, adaptive functioning is inherently chaotic. Successfully managing a medication schedule or navigating a grocery store involves overlapping obstacles, intersecting pathways, and unpredictable environmental variables that a sterile drill cannot replicate. Modern evidence-based neuropsychological rehabilitation targets functional outcomes, specifically a patient's independence and role participation. Overcoming the transfer problem requires treating cognitive deficits not as isolated processing errors, but by applying a multimodal, domain-specific approach. Optimal rehabilitation abandons the isolated drill in favor of goal-directed practice. It embeds the patient within a family-inclusive, interdisciplinary model of care. Because isolated exercises fail to reliably improve adaptive functioning on their own, a clinician's success depends entirely on systemic interventions matched directly to the affected domain. When a rehabilitation specialist designs a treatment plan, they face a fragmented landscape of therapeutic options, ranging from behavioral coaching to digital memory games. To organize the interventions with the highest clinical efficacy, we use this framework, the evidence synthesis matrix. Along the x-axis, we define the three core clinical domains of patient impairment: the conceptual, the practical, and the social. On the y-axis, we place the highest support clinical toolkit available to the interdisciplinary team. This toolkit is populated by foundational modalities with the strongest empirical backing: cognitive rehabilitation, compensatory strategies, psychoeducation, ADL training, and errorless learning. The core operational rule of this matrix is precision. Interventions only yield optimal functional outcomes when they are systematically matched to the specific domain they are designed to treat. Randomly applying an intervention without cross-referencing wastes clinical resources and stalls independence. The conceptual domain deals with the underlying mechanics of thought, deficits in memory, attention, executive skills, and problem-solving. Bringing the matrix back, we map the first targeted intervention for conceptual deficits. Here, cognitive remediation drops into the y-axis and draws a direct line to the conceptual column. Instead of having a patient play isolated memory games, this remediation is tied directly to goal-directed daily tasks. Working memory is trained by actively managing a complex daily schedule or organizing a real medication regimen. We then map the secondary interventions for this domain: external aids and metacognitive strategy training. These are evidence-based compensatory tools. They include physical memory notebooks, smartphone reminders, structured checklists, and environmental prompts. These compensatory strategies are heavily utilized when a patient's native neurological restoration is severely limited, effectively bypassing the damaged neural pathways. Mapping the conceptual domain with these specific tools provides the vital cognitive scaffolding a patient requires before executing physical routines. Once the conceptual scaffolding is in place, treatment shifts to the practical domain. This is the physical execution and habituation of instrumental activities of daily living, or IADLs. Returning to our matrix, we map the primary structural interventions. The node for occupational therapy and environmental modification drops in, linking directly to the practical column. The empirical data is clear. Task-specific training utilizing real-life environments is an absolute necessity. To achieve this practical execution, clinicians rely on a specific evidence-backed mechanism: errorless learning. When explicit memory is compromised, allowing trial and error risks encoding mistakes. Instead, the clinician guides them flawlessly through the task. Spaced retrieval then forces the patient to recall that flawless practical routine over slowly increasing intervals of time. This shifts the cognitive load, moving reliance away from explicit memory. These interventions hardwire reliable daily habits, allowing function even when memory deficits remain. The final domain is the social domain. This encompasses the contextual and interpersonal layer of rehabilitation, specifically awareness, coping mechanisms, and communication. Looking at the matrix one last time, we map the interventions that stabilize this foundation. Psychoeducation and communication coaching drop into the grid, connecting directly to the social domain. Psychoeducation is critical. The patient and family unit must be thoroughly educated on recovery expectations. Secondary social interventions complete the map, adding group-based awareness training to the patient's routine. Data consistently shows that holistic outcomes reach their peak when the family functions as a fully integrated member of the interdisciplinary treatment team. Interventions in the social domain act as an environmental stabilizer. Without this support system, the gains made in the conceptual and practical domains rapidly degrade the moment the patient is discharged from the hospital. The fully populated matrix functions as an interdependent clinical nervous system. Clinical test performance remains a useful metric for tracking deficits, but real-world functional independence is the sole definitive goal of rehabilitation. Successfully executing a complex IADL, whether that is navigating community transit or adhering to a strict medication schedule, requires the simultaneous activation of the conceptual, practical, and social nodes within this network. No single restorative or compensatory intervention works in a vacuum. Efficacy is found entirely in how these methods overlap and reinforce each other. This framework yields one final, overarching, evidence-based conclusion regarding adaptive functioning in neurorehabilitation. Adaptive functioning improves most reliably when rehabilitation uses individualized cognitive rehabilitation combined with compensatory supports. That cognitive work must then be paired with thorough psychoeducation and task-specific practice in real-world environments. And all of these components must be delivered within a family-inclusive, interdisciplinary model. This robust, multi-layered framework provides the contextual depth that fragile, isolated drill-based models lacked. Clinical efficacy is measured by the creation of a highly integrated systems-level model that ensures real-world role participation and lasting independence.